The previous lectures were about coronary artery disease and how remodeling is taking place there and how this influences cardiac mechanics. What I want to do is now go to one of the other kind of entities, etiologies, whatever you call it, and try to look a little bit what volume loading and changes in volume loading is doing with the heart. So it's always good to go back to what's happening with function, because in the end, that is what is driving the whole remodeling and what we measure. So as we said before, you have to look at happening at the level of the myocytes, and the amount of deformation they can do after being activated, and the amount of force development, of course, also that is turned into pressure. And it's especially the amount of deformation is important when we go to volume mode, because what you have to keep in mind is that single cells, as I said before, they can kind of shorten 10, maximally 15%. Also, there is relatively little modulation possible there. So as I said before, you can change deformation acutely a little bit, but not a huge amount. So this is important to know what's happening when you have remodeling, for example. The other thing that I also said before is obviously the geometry is very important, and we'll come back to that in a minute. It's not only the size of the ventricles, but also the shape of the ventricles, which is important, because the shape very much determines on how the force development and the deformation of the individual myocytes that are oriented, kind of, as we said, very complexly within the wall, how that is being translated into the cavity, where pressure is, of course, perpendicular to the endocardium. And the deformation is, of course, done by the whole walls. Now, as I mentioned before, also, it's the volume which is important in some ways. So you really need to see how the ventricles can generate the volume that is needed to be ejected. So one thing is that this volume changes with different conditions when you're doing exercise or when you're doing rest, for example, then you have volume changes. But of course, also, if, for example, you would have problems with leaking valves or with shunts or something like that, you will also have volume changes. And so these volume changes somehow have to be compensated in order to keep the volume flow or keep the cardiac output that goes to the regular, so to the periphery, to the body. Now, there's one thing which is really important to keep in mind, and that's actually the relation between the size of the ventricle, the deformation of the ventricle, and the stroke volume of the ventricle. Because what you see is, like, if we have a certain ventricle, what happens is if you have a certain amount of deformation, so you have deformation, this deformation will move the endocardial wall inwards. And what you will see is that changes the inner cavity, and that's the volume that's ejected. So that's the stroke volume. And so ventricle certain size, deformation moves the endocardium inward. And what you see is it's this kind of change in the volume between, of course, before and after the deformation. That will be exactly the stroke volume. Now, of course, with increased deformation, you will increase the stroke volume. But what's also the case is if you increase the size of the heart and you keep the strain constant, so you have the same amount of deformation of the tissue, what you will see now is when you look at the displacement of the endocardium and the amount of volume that is being displaced this way, it becomes much, much bigger than with a smaller ventricle. And just to show you how that relationship with size is also going on, it's like here you see, say that you have a sphere with a diameter of 8 centimeters, roughly a big ventricle, something like that. If you now would dilate with 1 centimeter everywhere, so your diameter becomes 10 centimeters instead of 8 centimeters, so it looks like a little bit of dilatation. What you see now is that the extra volume that you create is actually exactly the initial volume. So you double the volume inside the ventricle just with a little bit of dilatation. So you can now already imagine that if you have a ventricle with a certain amount of strain, generate a certain amount of stroke volume, you dilate a little bit, you can, with the same amount of strain, can eject much, much more stroke volume. And so if you're in situations where you need to generate more stroke volume in order then to increase the cardiac output, with exercise, for example, with leaking valves, with shunts or something like that. Dilatation is a way to, with the same myocardium, with the same myocytes working under the same kind of deformation conditions, be able to increase the stroke volume. Now, similarly, it also works the other way around. So if you have a certain ventricle and now you have, because of perfusion problems, ischemia or whatever, you have a problem with the tissue. So you're not able to deform as much as you should. What now happens is, of course, that if you increase the size of the ventricle and you have less strain, you can actually still generate the original stroke volume. So dilatation with retained strain increases the stroke volume. Dilatation with reduced strain maintains the stroke volume. So you can dilate either to compensate for volume overload, or you can dilate to compensate for a problem with the tissue, a problem in contractility that you cannot deform so much anymore. And so that's why you see clinically, you see dilatation in the patients that have volume overload, you see dilatation in the patients that have tissue damage. So in the end, the dilatation is very similar. It's in order to change this relationship between size, deformation, and stroke volume. And you can actually, and this is some kind of simulations that were done, you can actually kind of study this relationship in more detail. So as we said before, these three variables, strain, stroke volume, and size, they are mathematically related. If you know two of them, you know the third. And so you can really see what happens when you have increasing strains, for example, with a certain volume. Of course, you increase your stroke volume. If you have, if you need increasing stroke volumes, you can do that either by increasing strain or by increasing the size of the ventricle. And so you can really look at these relationships. Which also, of course, shows that if you're now going to do clinical studies, for example, where you would compare, for example, the deformation between groups of patients, or you would compare it before or after an intervention. And during that intervention or between these different patients, the sizes of the heart is very, very different. Then, of course, you have to be very, very careful to interpret the deformations, because as we said before, they are related. So you cannot study one, not keeping in mind the other one. I think that is really, really important. So, and then you can see that different hearts will work under, you can say like at different working points. So that's where you can see, like, for example, say that you would have a normal heart. The normal heart has a certain size. It has a certain stroke volume. That is also the ejection fraction is related to this, of course, and that's because of this longitudinal strain. If you now have a volume overload, what happens is, of course, the strain remains the same. So there's no reason why you would increase the strain. Your ejection fraction actually also remains the same. It might increase a little bit, but not necessarily, but you get your stroke volume, or you increase your stroke volume by increasing your size. And so by working at a different point here, by having this increase in the size, you're able to compensate for this need of increased stroke volume. Similarly, if you would have a problem with the deformation, so your deformation would be down, you have some tissue damage, you have some ischemia, what you will see then is that by dilating, you can actually maintain the normal stroke volume. What you see now, of course, also is that the ejection fraction can go down. So the ejection fraction and strain are related. So that's where you see that in these dilated ventricles, which are dilated because of problems with the myocardium, you see decreased strain and very often decreased ejection fraction, while in the volume overloaded one, you see bigger hearts, but with normal strains and normal ejection fractions. Sometimes even you get super kind of normal ejection fractions, but at least they shouldn't be decreased. So this is important. So every individual will start at a certain, or will be at a certain starting point. Of course, while doing exercise, you can again modulate this in order to compensate for the volume loading that is needed for the exercise. But these general remodeling, so changing the volume of the heart, of course, that takes a while because you need to get the chronic remodeling in some ways in order to get that. Now, One thing is also important to understand what the consequences of dilatation could be, is that you have to also keep in mind always the wall stresses, because as we said before, what is important for any adaptation, for any remodeling, for any problems, it's in the end what the myocyte sees. So it's really a certain myocyte somewhere within the ventricle, somewhere within the wall. The working conditions of that myocytes are the most important, because that will induce remodeling, yes or no, or failure at some point. So in order to understand what is the stresses or the wall stresses that a certain myocyte will feel, then this is where the shape comes in. And so if we look at the law of Laplace, that says that the wall stress in a kind of ventricle, a simplified ventricle, is related, of course, to the pressure. So if you have increased pressure, of course, the forces that the myocyte feel will increase, but it's also related to the radius of curvature. So you see that a small ventricle with a small radius of curvature for the same pressure has a much lower wall stress than a large ventricle, which intrinsically has a larger radius of curvature. And this is inversely related to the wall thickness. So thicker walls will also, again, have lower wall stresses for the same pressure. This is important for when we talk about pressure remodeling. But what is now important is that, of course, when you have your ventricle and you start to dilate, while the dilatation is good in order to generate more stroke volume with the same strain, or generate normal stroke volume with decreased strain, the disadvantage of this dilatation is that actually you increase your radius of curvature more and more, and thus you would increase your wall stress. So that means that the myocytes will be more and more feeling like higher wall stresses. And of course, at some point, when the wall stress becomes so high, they still fail. So first of all, these wall stresses will induce some type of remodeling. But secondly, the main thing is that there's a certain threshold after which the myocytes just give up, they fail, you get apoptosis, you get fibrosis. So that's also the reason why we have a certain size of the heart. So which is again an optimum between the size, the shape, and the wall stresses. And then, as I said before, also in one of the previous lectures, the trabeculations also play a role. So all of these parameters will be optimized in such a way that in a normal ventricle, the myocytes are under optimal conditions to function. So this is important to keep in mind. So larger hearts have higher wall stresses. Now, what's happening when we have this volume overload? So what is happening in general is that in order to generate this increased volume, of course, we have to increase our filling. So that means that mostly your end diastolic pressures will increase. So you will have more atrial filling, for example, also. So the end diastolic pressures increase. And if you chronically have increased end diastolic pressures, what happens is that your myocytes, within the myocyte, what they will do is you will have kind of the release of growth factors that will do a serial replication of sarcomeres within each cell. Every cell will lengthen. And of course, if every single cell will lengthen, what happens is that the whole ventricle dilates. And the trigger here, because in the end, it's the individual myocytes that have to remodel. So the trigger here is the higher filling pressures in order to get the filling. So that's what's happening there. Now, if we start looking at some patients with volume overload, for example, to see what's happening now is then, so here is a study of patients with mitral regurgitation. And so you have different groups of controlled and mild, moderate, and severe mitral regurgitation defined from the regurgitant volume. So mitral regurgitation, that means that you have a leaking mitral valve. That means that during the ejection phase, the blood is not only going to the aorta, but the blood is also going back to the left atrium because of this leaking mitral valve. And so you see, the more regurgitant volume you have, the more you will see that these patients, because they're chronic patients, that they will have dilate. And so you see a virtual linear relation, although what you start to see is that with the bigger regurgitations, it seems that there seems to be some kind of deviation from linear, but especially in the beginning, it is more or less linear. So this is the clear, what we said, the physiological adaptation, where a ventricle will grow in order to increase the stroke volume that is needed because of this regurgitant volume. Now, when we start to look at deformation, and you can look at rate of deformation, so the strain rates, or you can look at the deformation itself, what you now start to see is that when you look at the controls and the ones with mild, moderate regurgitation, what you will see is that the deformation remains quite constant with the size. So you see there's no clear kind of change with the size. But when we go to the larger ones, what we now see is that with the larger ones, it looks like the deformation is going down. But also keep in mind, it's not going down for all of them, because what you see there is that say roughly half of these patients with a very, very dilated ventricle, they have very decreased deformations, but there's another half which have actually more or less normal or retained deformation. So you see that there's a split here in this deformation. Also keep in mind that currently, according to the guidelines, surgery is mainly based on sizes. So a size, for example, of kind of roughly 5-6 centimeters or something like that, depending on which guidelines you use, that would be an indication for surgery. But you see that in these big ones, there are patients which are very, very different, while they're much more homogeneous in the small ones. Now, what is going on there also, and there's like some interesting studies also to understand a little bit more of the volume loading. As I said before, I've been talking about rotation and torsion. And so rotation and torsion, what you have is that so the base and the apex, they rotate differentially with regard to each other. And the reason for this is, of course, what I said before, is like when you look at the fiber orientation or the orientation of the myocytes within the wall, what you see is that endo and epicardial myocytes, they are oblique. And of course, when they contract, what they do is they drag the base towards the apex, but at the same time, they rotate the base from the apex. And so what you have is you have rotation during systole and then the derotation or twisting, untwisting during diastole. Now, there's a couple of studies in volume overload regarding to this. It's like, I myself am not a big fan of using rotation in clinical practice to do measurements, but it's interesting just to see what's happening. So just to understand it a little bit better. And when we look at chronic volume overload, so patients with mitral regurgitation, for example, what you see there is that the amount of torsion is not changing, but you see that the dynamics is changing. You see that the ones with overload are seem to rotate a little bit longer, and in total also their ejection seems to be a little bit longer. And then you see that they would derotate or untwist later and potentially with a little bit of less twist. And then especially the slope here is also changing. So this is clearly related to the fact is that, of course, the amount of rotation for a certain heart has to do with the amount of inflammation. So if you have more strain of the individual fibers, of course, you will rotate more. So this indicates that, of course, there is similar amount of deformation and thus similar amount of rotation. Now, the only thing that you see is that this timing is changing. And here we can come back to later on when we talk about pressure loading. What you will see is that, of course, because of these very dilated hearts, the wall stresses become higher. And this is related very likely to these wall stresses. But we'll come back to that later on. But you see clearly that what you have is when you look at the deformation or the displacement, you see that there's much more radial displacement, which is, of course, because you have a bigger heart, it looks like you have this bigger displacement. Now, here is an example of acute volume loading. So where you do an acute infusion of saline. So that means that here the heart didn't have the chance to grow. But of course, if you put volume in the ventricle, what you do is you will inflate it a little bit. So what happens is you indeed increase the size of the heart a little bit when doing an acute infusion of volume. Now, the other thing which is very important here also is that when you do an acute volume change, you have something which is called the Frank-Starling mechanism that comes in. And the Frank-Starling mechanism says that if you can stretch tissue for the contraction, what happens is that you can actually have more contraction. You have more force development and you have more deformation. More deformation is logical, because when you, of course, first stretch the myocytes, they can deform more. So you can increase your strain by initial stretching. But also there is this change in force development, which has to do with overlap of actin and myosin. And by stretching, you can optimally increase this. So you can really increase both the contractility and the amount of formation that you can do acutely by stretching this tissue. And that's called the Frank-Starling mechanism in the heart. Keep in mind, this is an acute mechanism. This is not true with chronic dilatation. Unfortunately, in some papers, you see that also as kind of explanation of changes in strain in acute or in chronic loading changes or in chronic size changes. But stalling is something acutely. You have a certain ventricle and then you blow it up and then you have these changes. And so you see here, when you now look at the deformation, in this case torsion, but as I said before, that's very related to the deformation. What you see is that you can acutely increase your torsion and your deformation with an inflation, so with an increase in the loading. So that's important also to keep in mind, this difference between acute and chronic situation. And similarly with exercise, what you do is you also increase your volume. So what you can do is, so you can increase this deformation with exercise. But keep in mind here also, and that's what I told you before, so this is a little bit similar to when you do the butamine, for example, at higher heart rates, so at higher peak exercise, you're not increasing your deformation anymore. And you see that also with the torsion, you see that very, very similarly. So at some point, your heart rate, as we said before, is too high. You do not have enough time to fill anymore, which means that you cannot eject what you haven't filled, which means that, of course, your deformation goes down. And that's what you can see here. Here nicely also, you see that in a displacement torsion loop. So you see again, displacement will rapidly increase initially, and with it linearly, you have an increase in this torsion. But at the higher levels of exercise, you have no increase or even a decrease at the highest levels, depending on your heart rate. Now, when you look at the literature, and this is also some publications that we've been doing when I was working in London with the group there. At some point in some paper on mitral regurgitation, we suggested that what would be interesting is to try to combine or find some way to describe the effect of the size and the effect of the deformation in some ways. Because what we see, what I showed is that there seems to be a discrepancy at some point with the very dilated ones in deformation, where a subgroup has low deformation and a subgroup has high deformation. So at some point we said, like, okay, let's do an index where we do a geometry compensated deformation. And there, of course, what you do is you exaggerate some of these differences. Now I'm not convinced anymore that this would be the best way of doing it. And I think in general, doing ratios of things is not the best way. What is probably better is to try to look at their relationship in some ways and how it's changing. So you will see that in some publications, but probably I wouldn't use it anymore. Now, what can we do with this? How can we understand this? And what are the consequences? Can we use this also in some ways? And what you can see from these studies is now, if you're going to study these patients at baseline, and then you, in the ones which have the big hearts, according to the guidelines, you do surgery, you replace the valve, so you take away the volume loading. What does it tell us anything about the success of this operation? So can we predict the success of the operation before, depending on using, for example, the deformation? Because this is a tricky thing in some ways, because with mitral regurgitation or any regurgitation, it's like you have to make sure that you do an operation before you start to get damage of the myocytes. So before, as we said before, this growing of the ventricle will increase the wall stresses and then potentially at some point induce myocyte damage. So you want to do something before. But of course, with valve surgery, you do not want to do valve surgery too early, because of the fact that every valve that you would implant has a certain kind of lifespan. We can come back to that other time. If you use biological valves, that means that after 10 years or something like that, you have to do a reoperation. So in young patients, you do not want to do that. You can use mechanical valves, but of course you need to keep on taking anticoagulation or some kind of rat poison in order to make sure that this valve keeps on functioning properly. So you really do not want to do early surgery, but you definitely do not want to do late surgery. So you really want to try to find a point at which the risk of damage of the myocytes is starting to increase. And what you see here in this study, so looking at the deformation before surgery and then the ejection fraction as a rough kind of functional parameter after, what you see is that there seems to be some kind of relation with it. So what is clear is that the ones that before surgery had very low strains, they have low ejection fraction and really abnormally low ejection fraction afterwards. While the ones that have normal strains, what you see there is that they have much, much better ejection fractions afterwards. And so it's both true for strain rates as well as strains. And similarly, this is aortic regurgitation, where you look at, if you would look at the group that has low strains before surgery, that's this group 2, or the ones that have normal strains before the surgery, what you will see there is that during follow-up, they will do very differently. You see in all of them that there's an acute decrease in strain. So that is because when you take the volume away, then, because what I said before, in order to increase the stroke volume, you can dilate or you can increase the strain also a little bit. And so these patients, they do both. They increase the strain as much as they can, but that's not a huge amount, but they compensate mainly by the increase in size. But so you see acutely always there's a sudden decrease in the deformation, but then in the ones that had good strains at the beginning, you see that the strain remains the same. And they also kind of do reasonably well. While what you see with the other ones, what you see there is that they have much more decrease and they never recover. So the ones that had low strains before, they will never recover to normal strains afterwards. And here you see a similar study. Again, this is aortic regurgitation. So you clearly nicely see here that the ones that had low deformation in strain or strain rate, that they have bad ejection fraction afterwards. And so you can really find this relation. There's also like another study showing the same thing. So you see that using deformation, you can actually try to predict what's going on after the surgery. So now, why is this? Well, obviously, this has to do with this, what I said, this compensation mechanism. So what you see is that first, when you start to have volume overload, you need to compensate for this. As I said before, there's two ways to increase the volume output. Is one, dilate. With the same amount of strain, you increase the stroke volume, or of course, increase the strain a little bit. Then, of course, you would also increase the stroke volume. This is perfect. This is what we call physiological adaptation. And this goes well for a long time. But then at some point, you will see that the heart becomes so big that now the wall stresses are disproportionately increased in such a way that the wall stress becomes so high that you locally start to get kind of problems with the myocyte. So you start to get apoptosis, the myocytes will die, you will then have it replaced by fibrosis. And what happens now, of course, is that if you have myocyte damage, what happens is that, of course, the amount of deformation that you can do will decrease. So your strain will decrease because of myocyte damage. Now, when your strain decreases, of course, your stroke volume will decrease. That means that you're not compensated anymore for this regurgitant stroke volume. That means that you have to compensate for that again, which means that you have to dilate in order to compensate for the fact that because of the decreased strain, you cannot generate the stroke volume anymore. So you dilate more, but of course, even if you dilate more, wall stresses will increase more, you get even more damage, which then has to be compensated by more dilatation, and you come in this vicious circle where you start to get myocyte damage compensated by dilatation, inducing even more myocyte damage. And this is also the reason, it's like if the patient topples to this point where there's damage and you need to dilate more to compensate for this damage, this can be very, very fast. And in the clinic, what you see is that typically regurgitation patients, they will deteriorate very, very fast in a couple of months, for example. So that's why, for example, a severe regurgitation follow-up would be every 6 months, for example, instead of every year where regular follow-up would be. So you really need to find this point when it starts to get better, get worse. So here is like finding this point when the deformation goes down. That will help you in order to see where the damage is being induced. And then obviously, as soon as deformation goes down, then you immediately have to do something in order to avoid some more damage. Now, partially related to this, and we will come back to this study later on, or these kind of principles later on also, it's like keep in mind that, of course, the stroke volume is generated by both your longitudinal and your circumferential deformation. And so what you will see in these patients also is that the longitudinal, of course, because the wall in the longitudinal direction is much flatter than in the circumferential direction. So always the longitudinal parts are damaged or potentially damaged earlier, or at least will decrease earlier if the wall stress increases. And partially this can be compensated by circumferential. And so you see here is an illustration for heart failure patients, but it's very similar to when we talk about regurgitation patients, for example. So what you will see is that with increasing size and increasing wall stress, what you see is that also your longitudinal deformation will start to go down, and that will be compensated by your circumferential deformation so that your stroke volume and your ejection fraction will actually remain more or less constant. Of course, now at the moment that you start to get problems with the myocardium, what you then see is then not only, so then you cannot compensate anymore in the circumferential direction. Then of course also your deformation in the circumferential direction goes down. And it's only when this is very, very much down that you start to see changes in the ejection fraction. So here again, looking at longitudinal deformation will always be the most sensitive in volume loading also, because that's the one that will start to go down first. And so it might be that if you sensitively look at this, that you're at a point where this is partially compensated by circumferential, and then of course you don't have immediate myocyte damage yet, and this is the point where you have to intervene. That's what you see also, is like when you look at regurgitation patients, what you often see is that this looks like a hyperdynamic kind of ventricle, especially in the conventional direction, because that's the one that is partially compensating for the longitudinal. Now, as last, and again, this is something that we come back to later on, this also can help us understanding some of the remodeling that is taking place, for example, in athletes. So, because what you see there is you need to increase your cardiac output when you do exercise, or you have to increase your cardiac output when you have volume overload, and your cardiac output is determined by the heart rate at one point and the stroke volume at the other one. And stroke volume you can change by changing your size or by changing your amount of deformation. And so when you look at athletes, for example, you see that they have these large hearts, because with a large heart, you can, with the same amount of deformation, or even with increased deformation, you can dramatically increase your stroke volume. But of course, if you have this large heart, with every heartbeat, you generate also an enormous amount of stroke volume. And so what you see there is that athletes have very low heart rates because of the fact that their stroke volume is so big with every heartbeat that they need to beat much less in order to keep on generating the cardiac output. And what you very often also see in athletes is that it looks like they have less deformation at baseline. And that's not because there's a problem with the myocardium, but that's actually because the fact that they don't need it. Even with low deformation, they can generate so much stroke volume with every beat that they already can generate the normal cardiac output when not doing exercise. And then interestingly, but again, that is something to discuss in more detail in another way, is that individuals can actually modulate this in very different ways. So you see individuals that need to increase heart rate in order to increase the stroke volume or increase the cardiac output. There's others that purely dilate. There's others that can change their deformation. And of course, there's some that where deformation decreases, again, because bigger hearts, as I said before, have increased wall stresses, where there's of course a chance of myocyte damage when this is happening. And so again, in order to understand this, it's all these parameters that you have to look at the same time and see how these are changing in an individual. And so you cannot one parameter that you measure in the whole population and then you do statistics. That's unlikely going to tell you anything about this. So you really have to look at in the individual and which are the physiological things which are related to each other. And this is how you need to look at it. Ideally, at this moment, we need to do this in our minds in some ways. So when we interpret this, we have to keep this in mind. Ideally, you can somehow also geometrically or mathematically link this in the future, hopefully with machine learning, maybe with some kind of physiological models. But this is something, again, to cover another time. Okay, I think that's enough for today. Do you have any questions?
But I have one question. So you have talked, you have said that when you dilate, you increase your wall stress, and it's more or less tolerated, well tolerated. But at some point, if the wall stress is too much, then damage starts.
Exactly.
Is there any evidence of, because this is mainly acute or subacute, because in the adults, no, if there is bad regurgitation, this will last months or years. But is there any evidence of what happens if chronically you have many years, like increased wall stress, if it's accumulative?
I don't think it's cumulative. Yeah, I think it's a threshold. I think it's a threshold. Now, the thing is, this threshold is, of course, it's not global, because, well, we haven't covered it yet, but what you see is that the ventricle is not a sphere. So you will have at different places, depending on the shape of your ventricle, you will have places where you have more increase somewhere else. And that's where you start to get fibrosis first. But I think it's a threshold phenomenon. Okay. Now, what is also the case, what is the case is that it's a chronic threshold in brackets. So because what can happen is, of course, as I said, if you do exercise, then of course this increases. So your wall stress will increase mostly with exercise. So what you see sometimes is that in athletes, for example, when you keep on doing this, then you might induce more damage. So again, it's a threshold, but you have to see is dynamically how often do you go over this threshold. Okay. So if you just go like half an hour over this threshold, that will not make a difference. But if every day you are exercising a couple of hours and you go over that threshold, then you start to get damage. So it looks like myocytes can recover from it. It's a little bit like with ischemia also. It's like if you acutely load this myocyte over a threshold, it will kind of acutely fail, but only if that is long enough, you will start to get damage. Because I mean, I don't know exactly what the molecular processes there are, but I mean, like apoptosis and so on is induced again by factors which are being released, and you need a certain amount of time there. But I think it's the combination of threshold together with endurance in some ways that will then induce. And then the question is, how reversible is this? Yes. So because some of it is reversible, there's some like animal experiments of athletes that are being done where you see that some of it can reverse and some fibrosis can reverse also. But of course, if you really have a lot of cell apoptosis, then I don't think it can reverse. So the question is also, again, when do you go over irreversible threshold? You don't know.
Okay, thank you.
Any other questions? Okay, then.
Well, yeah, I have a question.
Okay. Yes.
It's about the shape of the volume increase.
Okay.
Because I don't. Is it like a scaling or?
What do you mean?
So I mean, so if you have a volume overload, I mean, so your ventricle starts to fill, so its volume increases. Is it the same in every direction or not?
You mean whether it's uniform within the ventricle?
Yep.
Well, unlikely, because again, this is driven by end-diastolic stresses. So because of the fact that you have this shape change, what you will see is that I think where the end diastolic wall stress is the highest, and so it's your end diastolic shape that will determine that, there you will have more or earlier dilatation. But in the end, I don't think anybody has been looking at this, and I don't think it's also so easy to do it, because you would have to look really at your individual myocyte length. So I think globally it looks like a certain dilatation. Now, what is interesting is if you look at shape changes, for example, if you look at patients with mitral regurgitation, they seem to dilate reasonably uniformly, while aortic regurgitation, you see that the ventricle becomes quite strange in shape. But what you have there, of course, in aortic regurgitation, you have mostly a jet coming out of the aorta that hits the wall. So besides the fact that you have a increase in the wall stresses because of the shape, you will also have an impact of kind of a direct jet coming there during diastole. So you have increased diastolic wall stresses because of this jet there also, and that makes that the shape looks differently. But I haven't seen studies that look at this, and it would be interesting to simulate, for example, also. It's like try to simulate where the wall stresses are higher and then see how it locally would deform. But I expect it to be very, very heterogeneous indeed.
Okay, thanks.
Thanks for being here, and see you next week.